Hi everyone, welcome back to our, I think, 11th live stream. We're coming up on 1 year now of doing these, so we really appreciate all of you guys watching each month and asking your questions. We, again, have a record high number of awesome questions to answer, and we're super excited to talk about IV therapy, which is a topic that is near and dear to my heart because I was an IV patient of Dr. Jemsek's. Although it was very hard, it was very effective for me, so I'm a firm believer in it. Okay, really quick, for those who don't know me, my name is Julsey Capon, and I'm a Lyme literate psychotherapist here in the DC area, but I also work with patients virtually all over the country. And as I said, today we're mainly going to be talking about IV therapy with a few non-related IV questions thrown in there too. And I'm going to introduce Dr. Jemsek, and he has some really exciting news to share with you guys.
Well, first of all, I'm thrilled to have Jules with us, and I feel like we're the J&J team now. And if you get confused about which J, I'm the cute one. Well, we do have some exciting news. My colleague, Dr. Trad, a surgeon, and I wrote an abstract about subacute or chronic calculus cholecystitis, and it was accepted by SAGES to be presented in Las Vegas. SAGES is the Society of American Gastroenterology and Endoscopic Surgeons. It's very prestigious, very large international meeting, and the title actually includes the word Lyme. So I'm very proud of Dr. Trad. We're both thrilled. I referred the patients. He did the surgery. We had 65 in our abstract, 65 patients, and this disease is not in the textbooks. So this is a brand new disease, folks. You know, here's a new disease. Came out of this clinic and with Dr. Trad's help. And then the idea is that I'll write the manuscript next year after we introduce this topic and subject. So yeah, very exciting news, and really thrilled about that. Thank you.
We're going to start off by talking about, I think, the most important question, which is how do you decide if a patient needs IV therapy or oral therapy?
Okay, tough question to start with, but it's necessary. A lot of people think that Jemsek Specialty is an infusion mill. We're not. In fact, about 80%, if not more, of our patients go on to oral therapy. We reserve IV therapy for those who are highly incapacitated, particularly in terms of central nervous system dysfunction, those folks who've failed numerous therapies prior to that, to coming here, patient with gastrointestinal issues that are insurmountable. But the main criteria is advanced decrease in sensorium, ability to function. So people working on a 40 or 50% basis, people who can't remember what they read, and bear in mind, as you know, most of you do, we stabilize our patients at the beginning. And so if there are sleep issues or pain issues, those are handled to a satisfactory degree. Support issues are checked off. Laboratory work outliers are checked off. And mood issues are managed as well. Sometimes the patient will come in moderately impaired, and once they're stabilized, they improve, and so they're no longer a candidate for IV therapy. That happens. A lot of times it doesn't. So I would say overall about 10 to 15% of our patients qualify for IV therapy. There's another 5% or so that can't afford it, unfortunately, because the insurance companies have abandoned their mission. And we do our very best with that subset.
Do IV patients have more success with treatment?
Well, if they're in our category, they definitely do. Now, that's not to say we haven't treated severely impaired folks with oral therapy, but it takes forever. And again, we go through a stabilization and so forth. I don't think we get the same benefit. Now, what we're talking about with IV therapy is a progression of infusion medications, antibiotics, in combination with herbals, antimalarials, other oral antibiotics, and so forth. So it's not just IV therapy. It's a lot like chemotherapy in terms of doing combinations and doing sequencing and doing progressions. with priorities in mind.
All right, the next question is, if you live outside of the DC area and need IV therapy, how does that work? So well, maybe not most, but many patients are not from the DC area, are all over the country or all over the world, really. So how it would work is, first you obviously have to be approved by Dr. Jemsek or one of the other providers here for IV therapy. And if they feel like you're a good candidate for that, then for about a month or two, they're going to work on stabilizing your symptoms. So get your sleep under control, get your pain under control, stabilize your mood. Once they feel like your body's in good enough shape to tolerate IV therapy, then you'll work with the IV nurse, Sarah, who's unbelievable. And she'll set you up with an appointment either at a local hospital or at an outpatient facility, and you'll get your line placed there. And I'm going to go into more detail on what that actual procedure is like later. So you would fly into DC for a few days to get your line placed in. And then the next day, you come in to see Sarah, the IV nurse, and that's a long appointment, very informative though. And that's when she'll change your dressing, she'll teach you and your support person how to care for your line, and then she'll also test dose the antibiotic that you'll be using that month, or several antibiotics that you'll be using for that month, to make sure that your body reacts okay, you don't have a negative reaction to it. And then after a few days here, after you get your line placed, after you meet with Sarah the next day, and you're taught how to care for your line, then usually patients go home the second or third day, and you're given a protocol for about a month. Usually it's a Monday, Wednesday, Friday antibiotic treatment, and other days you're doing fluids, but that is pretty dependent on your own situation. And then you fly back to DC or drive back to DC about once a month, and you retest the antibiotics in the office. Sarah will look at your line, make sure everything's working okay. And the whole process is about 7 to 9 months. Dr. Jemsek is going to talk about how long IV treatment is in another question later on, but about 7 to 9 months, and you will travel into DC about once a month.
Thank you, Jules. Actually, it's not. Doesn't have to be every month. We're spread it out, and we can do phone consults in between once everybody's in rhythm. The idea of therapy is that it'll be done at home, and that there'll be a reliable support person or persons to help our patients and do the dressing changes after they've been taught how to do it. And really, they do a wonderful job. You think, well, maybe we should take them to the doctor. No. The support people do a much better job, and they're taught how to do it. If they have questions, we're on call 24/7. But coming in every 6 weeks on average, and if you're on the West Coast, we even try to stretch it out to the point that we think it's okay, but we need to see our patients, and they need to get test doses. So yeah, the therapy goes several days a month. It's a lot like chemo, and that you do block therapy and you do progressions, and you have downtime so that the toxins can be cleared. Just like with chemo, you're killing cells, and you're creating a great deal of waste with nucleic acids and various proteins and various cellular compartments that need to be cleared by the body. So we do it in sequence. We take advantage of the life cycles of the target organisms, and we prioritize what we want to kill. We can't kill all the pathogens and the co-infections in one fell swoop because they're very clever, they hide, and they're all slow growing. So it is a process. Should I show them Fred now?
Yes.
Okay, I want to meet Fred. Here's Fred. Say hi, Fred. So Fred has it's usually in the right side, but he has a left power pick in place that is placed in the subclavian vein, which then is threaded through the innominate vein and then to the superior vena cava. And it's secured with sutures, and it's very easy to work with. You see out here, this is the adapter, and that's where things are infused and flushed and so forth and so on. It generally is, there's mild sedation when it's put in, and we're in large veins now, so we're less likely to have clots and thrombosis, and of course we monitor the site very carefully. We don't want people to be sweaty. and macerated. Otherwise, we just do more dressing changes. Isn't that right, Fred? Do you like that? So, so Fred, thanks for everything. Did it hurt when they put it in, Fred? Ouch! I said it hurt a little bit. So, anyway, thanks, Fred. Good job.
All right, our next question is, and it ties into what you were just talking about, how IV therapy can be similar to chemotherapy. So the question is, does IV therapy for Lyme have similar reactions for patients doing chemotherapy for cancer?
Well, I think so, because there's a lot of cellular destruction, and remember, the infections that we're dealing with are invading cells and killing those cells as well. So it's not just infections. If you have an infected brain cell with a spirochete, that's a dead cell. Fortunately, we have 100 billion of them, but the good news is that we can reroute, reconnect, and redirect, and there is some regeneration of certain parts of the brain after the infections are purged. But yeah, it's a you need to give the patients way to detoxify and clear the waste. That's just necessary. And so I always compare it to chemo, because, for example, if you had a solid tumor and you had 8 drugs you're going to use, the oncologist doesn't come in and say, hey, we can be done in 3 weeks, we'll take all 8 drugs at once. And you got a puddle on the floor and as a patient. No, it doesn't work that way. And it takes combination therapy, because we have many, many targets, and there's no one antibiotic, 2 antibiotics, 3 antibiotics, herbals of any kind that can do the job by itself. So we've evolved this program to the point where it's been very successful, and we have certain landmarks that we can rely upon to tell us that the patient's getting better. And I can talk about that a little bit more in a moment.
Thanks, Dr. J. The next question is the IV placement painful? What was the experience like? So I know everyone has their own experience with this. For me personally, it was nowhere near as bad as I thought. I was really, really nervous going into the hospital where I got my Lyme placed. I thought, my God, there's going to be something going right into my chest near my heart, and I was really anxious. But as Dr. J said, they put you under very mild sedation. So I actually didn't even remember the procedure at all. Some people do, but I don't know. I didn't. And so when you check into the hospital or the outpatient procedure, the outpatient facility, you'll go into a room and they'll put an IV in you, and that's when they'll give you some relaxing meds or mild sedation to make you feel more comfortable. I don't even remember being wheeled into the operating room. I woke up about 15 minutes later, and it was a little bit sore. Not much. My arm, I think, to go like this, felt a little sore for about a week, and sleeping on it was a little bit sore, so I had to sleep on my back for about a week. But it was nowhere near as bad as I thought, and I think Fred would agree. It's not very painful.
So for our very sick folks, one of the advantages of having the power pick and having an access to your vascular system in large veins is that we innovated years ago and started giving people lactated ringers flushes or sometimes saline. The idea being to demarginate toxins in the blood vessels, because they abound there, as does biofilm. And this became a way for the person who can't exercise, can't get in the sauna, can't even stretch or tone. It became a primary way to help soften their journey through therapy and to help them detox along the way. So that's another big advantage. And I think there's a question later on, do people who, right?
The next question, yeah.
Is it the next? Okay, so occasionally we'll put a central line on someone just to do the detox and not provide IV therapy. So yes, that happens. Not terribly often, but yeah, we can do that, and we have done that.
A few months ago, I actually had a PICC line in. They placed a PICC line for me, or not them, but they ordered a PICC line for me just to receive IV fluids for a few months, because I had a big surgery coming up and I just wanted my body to be in the best shape possible. But this was years after I finished IV therapy, so not often, but as Dr. J said, they do sometimes put in a line for the benefit of IV fluids. Okay, the next question is a complicated one, but I think a really important one, which is, does insurance ever cover IV therapy?
Really?
I'm sorry.
You really want me to answer that? I think some people know about my history, probably a lot of people actually. So I just have to tell you, Blue Cross, took me to court in 2006. They had paid for, I don't know, a couple hundred of infusion patients when I was in Charlotte, and everything was authorized. I mean, it's not like we said, okay, we're going to put you on therapy and we're going to then check with Blue Cross. No, everything was authorized. Go ahead. And Blue Cross does this to people. They decide years later that, oh, we didn't really mean that. We want all the money back. And that's what happened. So we tried to play by the rules, and we got authorization, and yes, we were paid. And then later on they said, well, we didn't really mean that, so we need everything back. Now, here's how it works in our experience. Whether you're an oral or IV patient, insurance will generally cover your blood. It'll actually cover the PICC line infusion or PICC line insertion of our PICC. It will sometimes partially cover the office visit. It does not cover the fees for the infusions, except in a couple of cases. One, it seems like the federal insurance, federal health, does a little bit better with that. And of course, we're writing letters to support what we're doing, and we're getting ignored a lot, but not. Sometimes it's helpful. Now, here's the one group that seems to do the best are the people that are self-insured in a self-insured large company, and they're a employee of interest, and so they have leverage because they can go to HR and say, look, I need some therapy here. We're paying millions and millions in premiums, and we got a choice about changing insurance next year, and so insurance generally will go along with that. So we've had some very nice stories, and I think anyone that goes to infusion therapy, it's unfortunately a huge investment, especially in the time of COVID, because the insurance companies have abandoned their mission. Now, let me clarify that. I really don't like the idea of mandating that insurance companies pay for all infusions. Now, it sounds like I'm just doing double talk right now, but I'm not. Here's my point. It'd be the Wild West out there. What we really need is to develop a sensible program that has a good chance of success, not giving Rocephin for 18 months, for example, which is ridiculous. And if you can't mandate that insurance companies pay for everything unless we get an arbitration board of some kind with competent people, and it's a case-by-case decision. Otherwise, it's going to be chaos, and I don't think that's a good solution either. What we really need is more education, more training, more outcomes, and analysis, and better markers. And that's why it's such a shame that our GLA study was cut off by COVID, because we were the first group to do a study in combination with 3 universities to look at some of these markers and monitor the clinical progress of our patients in a sequential way using my therapy, and we lost it due to COVID. So COVID has hurt all of us, and it really hurt us here, and it really hurt the patient population with Lyme disease.
Thanks, Dr. J. Our next question is, do you believe there's a connection between schizophrenia and Bartonella? It's a really good question, because Bartonella and other tick-borne illnesses can mimic so many different mental illnesses. So if we take a look at schizophrenia, it's a really serious mental illness that changes how people think, feel, how they behave. It can consist of hallucinations, so hearing things that aren't there, seeing things that aren't there. It can consist of delusions, having really fixed false beliefs that are out of touch with reality. It's characterized by very disorganized thinking, people talking very fast, putting sentences together that don't make sense, and extreme paranoia. So if you look at Bartonella, it actually has a lot of similar symptoms. People with Bartonella describe having episodes of depersonalization or derealization, which makes you feel like the world around you or or yourself or the people around you are not real. You feel very detached from the outside world or detached from your body. And people describe it as they feel like they're kind of floating and just watching themselves. And so if you're talking to a mental health professional or any medical professional and you're telling them these symptoms of, depersonalization or hallucinations, a lot of times people with Bartonella or any tick-borne illness say that they hear mumbled voices, they see shadows that aren't there. So I think that there's a lot of misdiagnoses that happen, and people can get diagnosed with schizophrenia or some type of psychotic disorder, when it really could be Lyme, Bartonella, or another co-infection. But yes, the symptoms overlap significantly. Would you agree?
Yeah, thanks, Jules. So I found the most astute group of physicians, at least some of them, regarding mental illness, are psychiatrists. Because a good psychiatrist will listen to what the patient has to say and formulate it, understand the history, look at the response to previous medications, and understand that there's an organic illness here. There's an organic inflammatory encephalopathy, which is creating major mood disturbances, as Jules just said, ranging from, I gave my 4-floor analysis, I think, last time, starting on the first floor with irritability, and the top floor is depersonalization, psychosis, and so forth. But a good psychiatrist, and there are wonderful people in the country, have written wonderful things. One of them is Dr. Robert Bransfield, who's literally a phenomenal person who's done so much to educate, and a good friend of mine. So, organic encephalopathy. Well, look at it this way. Just from a common sense point of view, in our world, in our country, we have too many people with drug dependence, self-medicating. We have too many people with ADD. We have too many people with psychoses, bipolar. We have way too many people that are not functioning well. And is it something in the water, or is it something inflammatory? COVID is a big trigger. I'm sorry to digress, but COVID is putting a big blanket over the Lyme borreliosis pandemic. Unfortunately, we're going to be talking about COVID for a very long time, and now we have the word I hate, the long hauler syndrome, where folks have COVID, and then guess what? A few weeks later, all of a sudden, they can't process, they can't function. They have a pain they didn't have before. They have major mood disorders, and it just goes on and on and on. And so, are they reactivating Lyme borreliosis or some other disorder, or is this COVID itself doing it? Several of my patients have already said, I hear about the long hauler. Sure sounds like Lyme disease. And so I said, bingo, because I think we're going to see. Because after all, if you understand my concept of how the disease works, we need triggers, a series of triggers, or a major trigger to flip the balance and put the immune system behind trying to catch up the spirochete that's now racing everywhere it wants to go, along with its co-infections. And then from that on, the battle's lost. The deeper you dive, the harder it is to catch up, and you can no longer compensate.
I'm really excited for Dr. J to answer this next question, because I don't know a lot about this treatment at all. But the question that came in is, do you ever incorporate Dapsone into treatment? And if so, when do you think it's appropriate?
Yeah, I use Dapsone. It's a sulfone. It's a class of sulfones. It's related to the sulfa class. Of course, sulfamethoxazole is paired with trimethoprim to make Septrum. So I'll use Dapsone in combination with pyrimethamine and leucovorin and I'll use Septra in combination with pyrimethamine and leucovorin in our second or third stages of treatment to attack toxoplasmosis, which I think is an occult pathogen involved in this disease, reactivated, or other parasites. I think it's very effective. Also very effective in terms of breaking down biofilm. very effective. So when we treat people, we have a biochemical method with sugar alcohols to break down biofilm, and we have biologic methods. And I use Dapsone when I can't use Scepter when there has been an allergic reaction. Now, as some of you know, there are several stages of allergic reactions. Number one is angioedema. Somebody with sulfa gets, swelling of the throat or tongue, airway compromise. No, we don't use sulfa. We don't use Dapsone, which has a minor side chain of sulfa. So the cross-reactivity of reactions with sulfa is 10%, 15% the most. And then we use Dapsone even if it's just a rash with sulfa, we say, okay, let's not do that right now. Maybe we'll challenge you later. Because, sometimes rashes are not the downstream metabolic products of the molecule creating allergic reactions. Sometimes it's a herpes. I had the opportunity September in 2019 in Denver at a conference to sit for a couple of hours with Dr. Ying Zhang, who unfortunately is no longer at Hopkins. I'm not sure where he is. If anybody knows where he is, I'd love to know. He was very interested because, remember, he's the fellow who did all the in vitro testing of all kinds of combinations, and he's also looked at botanicals and for Bartonella and botanicals for the spirochete and the resting form. So we had a long talk, and I basically got some napkins out. I drew out my programs and the options that I had on programs, both for oral and IV, and he liked it very much. He said sometimes I think it's a little bit too much, but here's what I like. And he liked rifabutin much better than rifampin, and I was surprised to hear him say that he really preferred Sceptra over Dapsone. So that was an affirmation, and I thought that was, really good, and it was helpful that way, and I think I helped him, and he helped me. So we'll use Dapsone as an option for sulfa-intolerant patients.
All right, and next question is, how do I find mental health help for Lyme? And I love this question because Dr. Jemsek and other providers here won't even treat you unless you have proper support at home. We don't believe that you can get through this illness on your own. It's just too complicated. It's too hard emotionally, physically. And so there's a lot of options for mental health help. If your financial situation is a problem and if you need to get some free help, there's so many resources online. So my first suggestion would be going onto Facebook and searching for Lyme disease groups, and they have them pretty much on everything. They have Lyme disease groups for antibiotic treatment, for holistic treatment. They have Lyme and pregnancy groups. They have Lyme disease groups for pretty much every state out there. So if you go onto Facebook and you just if you just search Lyme disease groups, probably 50 will come up, and you can search through them and you can see which ones would be the best fit for you. And Facebook groups are a great option if people aren't comfortable talking out loud in a group and they really just want to sit behind a screen and hear people's responses or ask questions and get advice. If you want a little bit more of an interactive type support, then there's lots of different free virtual support groups, and you can find those on Instagram too. So I know Generation Lyme is a really big one on Instagram, and they hold, I think it's either monthly or weekly support groups. I'm not sure. Again, that's Generation Lyme if you want to search that on Instagram. And I also run a weekly support group virtually. If you search on Lyme, ONLYME on Instagram, you'll find that, and that meets every Tuesday. Again, that's completely free, and it's every week, and it's the best group of people. All people with Lyme disease. It's an adult group. I'm working on running an adolescent one coming up, so stay tuned for that. And then if you want something more individualized, then I would suggest finding a Lyme literate psychologist, therapist, psychiatrist. And if you can't find one of those, I know there are not a ton out there, you can go on the website Psychology Today, and you can search for a therapist who specializes in chronic illness. There's filters that you can type in what you're looking for, and chronic illness is one option. And all of the therapists or psychiatrists in your area who specialize in chronic illness will come up, and you can contact them that way. So that's my advice. Facebook, Instagram, Psychology Today, Googling Lyme literate therapists. Do you have any? Am I missing any?
No, you're a wealth of knowledge. It's
Okay.
amazing. But I did have a question for you.
Yes.
Some of the Lyme groups can be counterproductive, especially the ones where people are hogging the time on Lyme about their problems and their history, and there's a lot of angst among patients who've lost control of their lives. They want to control something, and so it's really counterproductive if somebody walk in and then hear all this bickering and arguing and this self-reporting. So say someone's new and you've just mentioned some good links. Can they tell right away that this is a group they shouldn't belong to?
Dr. Jay's right. Some groups can become really toxic, and there's been a pattern in groups where people are almost fighting for who can be the sickest. And I've seen that in a lot of groups that I've joined for myself. It almost becomes a weird sick competition, and those I would say stay away from. But any good group leader, if they're doing a virtual support group, will be able to monitor that well. And if they see someone that's taking over the group and monopolizing all the time, they should be able to talk to them privately or redirect the conversation and elsewhere. But if you're looking online or on Facebook, if you scroll through some of the posts and you see people reacting negatively to comments or saying, well, at least you're not bedridden, those types of comments, I would say stay away from that. I would look for very supportive group members, only positive feedback, because it can become very toxic, and I would hate for you guys to get into a situation where you're almost, again, like competing who was the most sick or who deserved the most compassion or attention. So that's a really good point.
Yeah, it's a thoroughly miserable disease and thoroughly misunderstood and thoroughly politicized. So I don't on that. I did something with the canned Lyme. They have a webinar going, or what do you call it? Anyway, I did 40 minutes of audio instead of 20, and I think I started to rant a little bit. So we'll see. They're going to edit it, and so I'm not going to rant here. But here's what I know and realize. I feel that this is a countrywide scandal, that this disease has not been recognized, that it's been contorted into several different disorders, with people saying it's not real. A lot of that comes from the fact that doctors of influence certainly don't listen to the patients, and they certainly don't examine the patients. So how can you learn anything? I mean, the patient is what we do in medicine. What is medicine without a patient? Tell me. What is medicine without a patient? The patient is the center. It's our canvas. It's our palette. And it's, if you don't have compassion in medicine, get the hell out. If you don't have patience and you think you know everything, get the hell out. Because we have so much to learn. And this disease is infinitely complex. And I've said many times it should be its own discipline. And I hope it is one day. I just want to also say that this is our 11th live stream. So we've had 11 hours online, which we hope has been educational. We've certainly geared it to be educational. There's so much misinformation out there. We try to be, I don't know everything, folks, I don't. But we know quite a bit, and my colleagues here, Kim and Rachel and Carrie and Candy, and former colleagues, Tara Fox, we learn a tremendous amount. And it takes a certain type of person to apply themselves to these complex patients. I have compassion for the millions of people who can't access care. I've done a little bit on our website with our self-help tools, which are easily located. I think it's a dozen or 14 pages that we created in England a couple of summers ago when I did a day lecture. And it's volume 1, and I hope to improve it one day, but it's not bad. It's just very basic. It's things anybody can do so long as they have a little bit of help and can get out of bed. So at least that's there for you if you want to check the website. I want you to engage in that, and I wrote it with Andrea Caesar and my friend Dermot O'Flynn, who's a London physician, and with the help of Lyme Disease UK, it was done. So it's on our website, and I don't think there's anything quite like that on the websites. It's things many people know already, but some don't. So please take advantage of that. There's obviously no charge, because again, I have great sympathy for those who can't access care, because it's a miserable situation.
I'm just looking at some of our comments on Facebook here, and I think a really good question came in, which is, if you take a break from treatment, does the infection get worse or does it stabilize? And I know last live stream we touched base on if you need to take a break during therapy, whether it's because, you know, your symptoms or your Herx reactions are becoming intolerable, or your mental health symptoms are getting really bad, or if there's any suicidality involved, we recommend taking a break from treatment. So the question is that okay to do, or does the infection brew, or does it stabilize?
So first of all, we do interrupted therapy. We give people downtime. If you're on continuous therapy, you can get into a toxic swirl if you're in fact killing, and that doesn't do your immune system any good. Remember, the idea is to purge the infections, repair the body, and restore the immune system to control. So the better you do, the less we do. So we build in breaks, and sometimes people need longer breaks because they get such a toxic reaction. Sometimes as the therapy progresses, as the immune system strengthens, the reactivity, the die-off is, even though the die-off is not as much, the activity is very great. Now remember, when you have a toxic storm on therapy, our patients are at a tremendous disadvantage because they have damaged sensory pathways, they have damaged brain, they have leaky gut, and their threshold for having mood or pain disorders is much lower. So, and if someone is having unacceptable side effects, we'll stop therapy and reevaluate. When we start therapy with our patients, we always say the key word is manageable. Mm-hmm. So if that's a key word. Just write it on your, write it on your bedroom wall. Manageable. Everything has to be manageable, and we've given you tools, hopefully, to do that, because now you know how to detox, and you're doing other things that, in terms of your diet changes and your supplements and so forth, that should benefit you. It has to be manageable. If it gets to the point where it's not manageable or you get overheated, we'll take a break, we'll alter your program and adjust your program so that you don't have this inflammatory storm, or at least it can clear soon. The reason is that doesn't do your immune recovery any favors if you get that inflamed. Mm-hmm. And for people that are just taking one or two medications at a time, you're not taking enough, and you're not doing it in an intelligent sequence. You're just not. We have many moving parts and many diverse life forms that we're dealing with, and both in cells and outside of cells, in biofilm, which has to be broken down, leaky gut, which helps fuel perpetual inflammation, and then you have to have a knowledge of at least 24 potential roadblocks that can absolutely stall out therapy. And we have listed some of those, I think. We've talked about some of those. We haven't listed all of them yet. Thank you.
I want to normalize that and let you guys know that so many people have to take a break at one point in their treatment. Not all, but a lot do. And I know I had to at some point in the few years that I was treating, because it can just get really, really hard. And I felt like after a few months off treatment, my body was in better shape and it was stronger. So a lot of people get discouraged when they have to stop for a month or 2 or 3 months, but it does happen often, and I think your body in the end will be much stronger because of it.
Yeah, we're trying to Thank you. We're just trying to find a balance point, folks. We have work to do. We have to do a certain killing. We have to do certain progressions. At least we think so. But we can improvise depending on the situation. But there are certain things that have to be in place: support, adequate control of pain and sleep, knowing what outliers you have in your metabolic reviews, and your mood being stable. So it's about balancing. And in our program, we find that I would say 80+% can follow our program successfully, and those that have unusual issues, or we interrupt therapy. So life happens. Sometimes a life event will change everything. We take a time out.
This next question, a lot of people submitted it, and actually a few commented on Facebook asking the same question too, so I think it's a really important one. And it is, on average, how long does someone do IV therapy for?
So we do 8 or 9 cycles over 31 to 35 weeks, and there's the number of dosing days during that time, and we're talking about days or so, is 66 to 74 dosing days. Now that doesn't, of course, you got your line in the whole time. You got line in every single day. Sometimes you're taking oral therapy and not IV, but I was talking about 66 to 74 days of IV therapy spread out over 8 to 9 months. And I have to say, with a whole diverse group of patients, that we know when patients will turn or start to improve, and we can see it, and we take our windows to look at that. And I have to tell you a funny story, because Andreas Caesar, who wrote the book Twist of Lyme, I put her on I call them holidays. When you first get off, when you take a little break. Sometimes, well, not sometimes. It's pretty common. Patient will say, "I feel worse off therapy." I feel off. And eventually that'll change. But the reason you feel worse is because the immune system's now a little bit pissed off. And when we do therapy, some of it is immunosuppressive, or not, suppressive, not immunosuppressive. Not everything is being killed, but some things are being killed. That's when you hurt. But a lot of suppression is going on, so things are quiet. The immune system quiets down. You remove that from the patient as you try to clear toxins and so forth. The immune system now is getting angry. And so a lot of time, well, most of the time through the first phases of therapy, those holidays are helidays, as per Andreas Caesar.
All right, next question is, what are your thoughts on ketamine infusions for treatment-resistant depression or suicidal ideations?
Well, I have only a little bit of experience, but I think it's an excellent tool. I can't do it myself because of liability issues. I have to have an anesthetist on site, and we don't. But I have experience with New York physicians and Northern Virginia physicians and even DC physicians where we've had good benefit from it. So ketamine is a very important player in the NMDA pathway system, which promotes pain and excitation and that sort of thing. So, and I think more and more people are getting into it, so I have no hesitancy about referring patients for depressive reactions, or there's a different program or protocol for pain control, which sometimes we need. Because for central pain, don't touch me pain, ketamine is one of the very few things that actually helps. Number one is THC in the form of Marinol, which is a synthetic THC, been around for 30 or 40 years. A lot of cannabis THC, a lot of gummies, a lot of edibles that help. And if a patient can get on Marinol, sometimes it's a godsend for them. Mirtazapine Remeron actually helps some. We sometimes combine that. We do ketamine sprays, which gets about 40% of the drug levels as IV. And that helps some people as well. But we can't, personally here, we can't do IV. Just can't take the liability, can't do it. But I think it's an excellent modality, and you're going to see more centers.
What do you think the hardest part of IV therapy is? So I know everyone will have a different answer to this, but for me personally, it wasn't necessarily that I felt more sick on IV therapy versus oral therapy. I think the hardest part was just the limitations that were placed on me because I had a line placed in my chest. So things like, and I know it sounds silly, but like showering was really annoying, and I had to like shower like this for a year. You know, you have to really limit the amount that you sweat. So not that I felt really great and to exercise, but on the days where I did want to, or especially towards the end of IV therapy when I was feeling better, you know, I really couldn't. You can't even pick something up heavier than I think a gallon of milk. And then just the time management of having a line in, you know, when you do your treatment, it's a few hours a day sometimes. The lactated ringers can take 2 or 3 hours, and the IV antibiotics can take, you know, an hour in the morning, an hour at night, or sometimes longer if you're doing several antibiotics. So I think, again, just the limitations that you have when you have something placed right here. You have to be very careful not to shift things around and get your line messed up, and then just how much time it does take administering your IVs, and then you have to change your dressing once a week, and you just have to keep things very clean, and it's a lot of management. So for me, I'm not very good at that kind of stuff, so that was really hard for me, but I'm sure everyone would have a different answer to this question. What do you think? What do your patients say is the hardest part?
Well, I thought you were very nice when you came in the office. You never acted angry. So, again, I want to emphasize only the sickest of the sick are considered for IV therapy. And again, we have to check all the boxes because it's quite an undertaking. But to get your life back, to get your brain back, and we've been able to do that. We've been blessed to do that. We have a gift to do that, and we have to follow our gift. And I just wish that it wasn't so politicized. But this disease will inexorably destroy the rest of the nervous system if not addressed. And I feel so much sorrow for children who are undiagnosed walking around with inflammatory encephalopathy. You know, they have no life ahead of them. They probably be headed to mental illness or drug abuse in a lot of cases. But I strongly believe that if you're selective about who's a candidate for IV therapy and that everything's in place, especially support, we've seen hundreds and hundreds of people get so much better, and there's a lot of love that comes back to us, and we're so thankful for that. And I just wish that we could take this disease by the collar and take a few hundred physicians by the collar and create a college and accreditation program and get the scientists on board instead of playing politics and going after the money, and take care of our population because it's affecting the human condition on many, many levels in a very serious and significant way.
I agree. I think I joke with Dr. Day, there needs to be a whole medical school just on Lyme because there's so much information and it's a really complicated illness. Okay, I think we have time for about 2 more. So the next question is, why do I have such a short fuse, as most people call it, Lyme rage? I touched base on this last live stream, but I think it's such an important topic, and so many people struggle with this, so I'll quickly address it again. But as I said last time, so many of my patients say that the worst part for them of this illness is not necessarily what it's doing to their body, but what it's doing to their brain. And Lyme commonly affects the amygdala, which is a component of the limbic system, and that plays an important role in behavior and emotion, particularly fear and anger. And so people describe this Lyme rage as this unprovoked, or sometimes provoked, this unprovoked anger that they feel like they're almost watching themselves explode. They don't recognize themselves. It's not who they are. People say, I was never an angry person. I was the most chill person. I was so laid back. And now they're screaming and crying all the time, or throwing plates against the wall, or yelling at, the people that are closest to them. And there can be a lot of shame and guilt around that because they know that's not really who they are deep down. But it can cause a lot of impulsive actions, a lot of really horrific thoughts. Some people will have homicidal thoughts, suicidal thoughts that, again, they just describe it as it's not who they are. So I won't go into too much detail because I know I touched base last live stream about it, but Lyme rage is a real thing with Lyme patients.
Yeah. Nobody screams at me much, but
Well, they have to be nice to you. You have the
nice
meds.
that's right. I call it the reptilian brain takes over. I call it Komodo brain, Komodo dragon. I got this great slide, that shows the dragon. And the reptilian brain overrides the prefrontal cortex, the amygdala. And so it signals the rage, and the prefrontal cortex is overridden and can't say and rationalize, what's going on. Because the limbic system brain, the subcortical brain, doesn't think, right? Doesn't think. So we have gray matter, white matter, okay? The gray matter thinks, the white matter reacts. So I call it the Komodo brain. And, but I don't get yelled at that much.
I don't either, but
I don't know.
it can get
maybe
bad.
because he's such a nice guy. I don't know. Maybe. I don't
That
know.
must be it.
Yeah, it must be it.
All right, our last and final question of the day is, how do you know when someone is done with IV therapy?
Great question, and I think that hopefully I've been able to frame out the whole picture of IV therapy, giving you terms of treatment, the amount of treatment, the number of sessions. And again, it's remarkable that the vast majority of people fit right in. And about the 6th month or so, you start to see a change. And about the 6th month, I start to stretch out time off from 1 week to 2 weeks, because we have immune strengthening and focus that's beginning, or at least we're testing that, and we continue to do that throughout. And whether it's oral therapy or IV therapy, what we want are blue sky days, and then we want blue sky weeks. And there's a tremendous correlation, very confident correlation with people who've had 10 to 14 days of blue sky, meaning that they're tranquil. Doesn't mean that they've got their full function back, but they're tranquil, they're able to process information, they're able to interact to the extent they couldn't before. If they can do 10 or 14 days in the holiday is no longer the holiday. And if they can do that for 2 consecutive cycles, I have great confidence they're going to be able to go to oral therapy or step-down therapy, and I'm right about 95% of the time.
Thank you all for watching, as always, and I don't know when our live stream is going to be, whether it's next month, in a few months, but please keep sending questions. We love your questions. We will get to them. And again, thank you so much for watching, and I'll see you guys next time.
Probably take a break in April, back in May. God bless.